guess it's time. You're welcome, everyone. My name is Nnamdi Moiteke. I'm a clinical assistant professor in the Department of Community and Public Health at ISU and the project coordinator of the Idaho Collaborative for Infectious Disease Prevention, which is hosting this event. So welcome to this presentation, which we intend to highlight the study on hepatitis C and treatment and testing in Idaho County jails, which is being conducted by partners from different organizations in the state, including the Eastern Idaho Public Health, Southeastern Idaho Public Health, Idaho Department of Health and Welfare, and the Idaho State University. So the presenters will take us through the history and background of this study, the study protocol, and what has been done so far, and their preliminary findings and future work as regards the study. So we hope that this presentation will spark discussions, not just on the study and the presentation, but also about the general issue of hepatitis C among incarcerated persons in Idaho. We have decided to use the Zoom meeting format to have more engagement and interaction. So please feel free to raise your hands and ask questions and make contributions at the end of the presentation. We will also be monitoring the chat for questions and contributions. So a brief introduction of the presenters. We have Rachel Mogelstein, who's a program manager with the Eastern Idaho Public Health. Irene Van Roden, who is an associate professor in the Department of Community and Public Health here at ISU. And Christine van der Grend, who is an associate professor and chair of the Department of Community and Public Health, ISU. And so over to you, team, and please feel free to tell us more about yourself.
Okay, so yeah, like Nnamdi said, my name is Rachel Mogelstein, Program Manager with Eastern Idaho Public Health. I'm also the Principal Investigator for the Hepatitis C study that we'll be presenting on today. Hopefully everybody can see that okay? All right, perfect. Okay, so we have started a research study for the testing and treatment of hepatitis C in the Idaho County jails. This is a pilot study that is currently ongoing. Just to give you some background, to understand why this work matters, it's important to look at the broader landscape of Idaho's justice-involved population and how it intersects with public health, particularly around hepatitis C. Idaho operates a complex correctional system consisting of 37 county jails, 9 state prisons, and 5 community reentry centers. Each of these facilities play a different role, but they all represent important points of contact for health services, including testing and treatment for hepatitis C. Nearly 38% of Idaho's incarcerated population is serving time for drug-related charges, and this highlights the close connection between the substance use and incarceration, and by extension, the increased risk for infectious disease, such as hepatitis C. Data shows that about 30% of Idaho's prison population is infected with hepatitis C, which is nearly 1 in 3 individuals, underscoring the need for accessible, consistent, and coordinated testing and treatment within correctional environments. In 2021, the Idaho Department of Corrections, or IDOC, settled a lawsuit that resulted in $13.3 million in commitment over a 4-year period to expand hepatitis C treatment for state prison populations. That investment represented a significant step toward improving care access, at least within the state prison system. However, Idaho's county jails operate independently and under local budgets, and those budgets typically do not include hepatitis C treatment funding, which creates a significant gap. While state prisons can provide treatment, individuals cycling through county jails often have limited or no access to care for hepatitis C treatment. Together, these realities show why research within county-level incarceration is so critical. County jails represent a key opportunity to identify, treat, and interrupt transmission of hepatitis C, especially among populations that are often underserved in traditional healthcare systems. To provide background on our process, I want to briefly walk through how our testing program operated prior to the study and how we attempted to ensure individuals were linked to appropriate care afterward. Eastern Idaho Public Health has provided STI testing in the county jails for over a decade. This includes chlamydia, gonorrhea, trichomonas, HIV, syphilis, and hepatitis C testing. It's important to note at this point that all testing conducted is via opt-in. Opt-out testing was a big source of conversation and discussed at length. However, funding and staffing constraints and shortages have prevented an approach for opt-out testing. So how the testing process works is a medical request form is filled out by an inmate. So the form is completed by individuals requesting testing services within the jail system. Those requests are submitted and gathered by medical staff at the county jails. A date is set in coordination with us and the county jail medical team, and we go and conduct those clinics as scheduled. Testing at the beginning occurred once a month, and then during each session, we completed comprehensive risk assessments, collected demographic information, and ensured informed consent is obtained. This helped us capture both health data and contextual factors that may influence care, access, or risk behaviors. When a result would come back reactive, we made every effort to, and confirmed positive, we made every effort to track the individual's release date so that we could connect them to community resources once they left the facility. Even when exact tracking isn't possible, we tried to document our attempts to link those individuals to care. Our follow-up processes focus on ensuring the individual understands their diagnosis, receives education as needed, and has a pathway to ongoing medical care or treatment. Individuals sentenced to the state prison system have access to treatment post-confirmed positive upon arrival to the state facility. With these two components, the testing process and the linkage to care, we aim to create a comprehensive approach to establish a broader effort to connect individuals with the care and support they need after their release. So this is going to start going through our, there we go. This slide walks through how the entire project came to be with the Gilead research study. Starting from a basic operational challenge and evolving into a full research collaboration. The starting point was the availability of CDC funding, which made venipuncture for confirmatory hepatitis C testing possible within the county jail setting. This was a major step forward, but that raised the next critical question with now that we can confirm the infection, how do we treat it? So at this point, we attempted patient assistance programs to pay for the medication to treat hepatitis C. Unfortunately, they were denied for patient assistance on the application due to their incarceration status. So the next question came up. What are our options now? From there, we reached out to Gilead to explore potential treatment options and research collaboration. Through those discussions, we were referred to research staff, and conversations began about how to develop a structured research opportunity to fill this gap. At that point, a research project was launched. Those discussions ultimately led to the formal research study. We launched a collaborative project in November of 2023 with the potential to enroll 100 eligible participants for hepatitis C treatment. The central question was whether county jails could serve as a feasible and effective environment for hepatitis C treatment. We were offering FDA-approved medications, so it was not a study on the efficacy of medications, but an environmental study. How does this work with the more transient inmates in the county jail? To support this, testing was increased to twice a month, and the team worked through protocol finalization and IRB human subjects research approval. So it began as a practical challenge. Identifying and treating incarcerated individuals with hepatitis C evolved into a collaboration designed to answer that very question and aim to inform public health practice statewide. On this slide, it outlines the original study design, which was established in November of 2024, and highlights key amendments that were made in 2025. The goal of these changes was to expand the study's reach and strengthen data quality while maintaining the integrity of the original framework. The original study design followed a 12-month timeline. Within that period, we had a 6-month enrollment window, followed by a 6-month post-enrollment follow-up and finalization phase. The study initially operated across 3 enrollment sites, which was Bonneville, Madison, and Jefferson counties in eastern Idaho, allowing us to monitor feasibility and establish consistency in data collection. In May of 2025, we initiated an amendment to this study to increase participation, extend opportunities to other sites, and extend monitoring. We were able to extend the timeline to 18 months to allow more time for enrollment and comprehensive analysis. The enrollment phase was doubled from 6 to 12 months to improve recruitment and ensure adequate sample size across all locations. And the 6-month follow-up period remained the same, just extending after the initial 12-month enrollment period. We added a 4th site, which was Bannock County Jail, to broaden geographical representation and increase participation. Initially, those people who were sentenced to the Idaho Department of Corrections were excluded for the study participation, as they had an opportunity to receive treatment once sent to the prison system. However, in May, this was ultimately decided to be removed from the exclusionary criteria to increase participation, and because many individuals sentenced to the Idaho Department of Corrections are held in county-level facilities for an extended period of time due to many factors such as overcrowding. Overall, these updates were designed to enhance the study's robustness, expanding participation, extending observation, and ensuring more meaningful results when the project concludes. This project would not be possible without a strong multidisciplinary team. Each of these partners brings unique expertise and resources that make the research both feasible and meaningful. From Eastern Idaho Public Health, we serve as the lead agency as the primary or principal investigator, coordinating overall project management, implementation, and data oversight. Our team, including myself, works closely with the participating facilities and partners to ensure protocols are followed and progress stays on track. At Southeast Idaho Public Health, that's led by Allison Weens. She plays a key role in supporting operations and ensuring continuity across regional efforts, especially in participant follow-up and data coordination. Idaho State University is our academic partner. They provide essential research infrastructure and expertise and data analytics. Dr. Irene Van Worden and Dr. Kristen Vandegriend oversee study design, data analysis, and evaluation to ensure the research meets academic and ethical standards. Gilead Sciences supports the study as a funding source, research partner, providing technical guidance, study materials, and clinical consultation. Their representatives, Karen Stevens, Jonah Street, Tisha Quinn, Carl Gustafson, and Melissa Jones have been instrumental in bridging research design and treatment feasibility. On the ground, our county jail teams and medical staff, including IV Medical and RHS Medical, are essential partners. They handle testing logistics, participant coordination, and day-to-day operations within the correctional setting. And finally, the Idaho Hepatitis Prevention Program, represented by Danae Schoenborn, contributes public health expertise and linkage to care support, ensuring that this project aligns with statewide hepatitis elimination goals. Together, this multidisciplinary team and collaboration combines public health, academia, correctional health, and private sector expertise, creating a unified effort to advance care and research for justice-involved individuals affected by hepatitis C. Next, I'd like to discuss our steering committee. A steering committee plays a critical role in guiding the direction, integrity, and impact of a research project. It brings together diverse expertise and perspectives to ensure the work remains relevant, ethical, and aligned with both community and scientific goals. As you can see by this slide, we had an amazing team for our steering committee. We asked the participants of the steering committee to participate in 3 advisory committee meetings, each lasting about 1 hour, held by a teleconference. Their participation is recognized according to the International Committee of Medical Journal Editors criteria. The committee provides strategic oversight, helping set priorities, monitor progress, and make sure the project stays on course. It acts as a sounding board for key decisions, ensuring that timelines, resources, and objectives remain realistic and achievable. Steering committees also foster accountability. By reviewing progress and outcomes, they help maintain transparency in how data is collected, analyzed, and reported. This structure promotes trust among partners, funders, and the communities impacted by this research. Members often represent a range of disciplines, from clinical experts and public health professionals to community leaders and policymakers. Their combined expertise helps ensure that the research is both scientifically rigorous and practically applicable. Having community representation within the steering committee ensures that lived experience and local perspectives shape the study design and interpretation. This helps make the findings more culturally responsive and improves acceptance of the project's outcomes. The committee also helps safeguard ethical standards, reviewing consent processes, participant protections, and data use. I'm sorry, that's supposed to be participant projections. They play an important role in ensuring that research practices promote equity and respect for all populations involved. Finally, the steering committee lays the groundwork for sustainability. Their connections and guidance often help translate research findings into policy, programming, or continued funding opportunities. A strong steering committee turns a research project from a single effort into a collaborative, credible, and community-driven process, ensuring that what we learn truly leads to meaningful and lasting impact. This slide highlights the progress we've made so far, from establishing a roadmap to enrolling participants and to addressing barriers and recognizing the successes that have emerged along the way. We began by creating a clear roadmap for implementation. This included mapping out the study timeline, identifying participating facilities, and tracking the number of enrollments over time. Having this roadmap has allowed us to visualize progress, anticipate challenges, and keep the project on schedule. Ideally, this roadmap can also be used as a tool for other facilities, counties, or states to guide them on implementing a similar process. This step requires coordination across multiple partners, establishing consistent policies and procedures, clarifying roles and responsibilities, and building strong relationships with champions within the jails who support and encourage participation. We also worked closely with the Idaho Department of Corrections to ensure all follow-up lab work or surveys were completed if individuals were moved to their facilities during their enrollment period. That buy-in has been essential for sustaining participation and data collection. Once the framework was in place, we moved on to the enrollment phase. To date, 16 individuals have initiated treatment. 12 of those enrollees are 12 weeks post-medication initiation, so should have completed treatment. Unfortunately, we have lost 4 individuals to follow-up. However, of those not lost to follow-up, 100% have achieved sustained virologic response at 4 or 12-week post-treatment. So 100% cure rate of those are not lost to follow-up. Throughout this project, we focused on identifying and addressing barriers while also celebrating what's working well. We've been monitoring barriers to uptake, enrollment, and completion to understand what helps or hinders participation. In addition, qualitative interviews with staff will be conducted and provide valuable insight into the on-the-ground experiences, what motivated engagement, what obstacles exist, and what were improvements that can be made. We anticipate this, this feedback loop being critical in refining our approach as we move forward. While uptake in this participation was smaller than anticipated, we have celebrated the successes with those enrolled along the way. Overall, this work to date reflects steady progress, not just in numbers, but in building systems, partnerships, and lessons that will strengthen both current and future phases of the study. So Irene, if you wouldn't mind.
Sure. So we have our preliminary results. I have, I believe, 15 participants that I had data for when I created this slide. And so one of the things that participants were asked was about their mobility, their self-care, the usual activities, pain, discomfort, and depression. So for anxiety, depression, it was a 3-part question saying, I am not anxious or depressed, I am moderately anxious or depressed, and I am extremely anxious or depressed. For mobility, it was about if they had no problems in walking about, some problems or moderate problems, or if they were confined to bed. For pain and discomfort, it was I have no pain or discomfort, or moderate or extreme pain or discomfort. For self-care, it was I have no problems with self-care, up to I am unable to wash or dress myself. And usual activities was asked, I have no problems with performing my usual activities, I have some problems, or I am unable to perform my usual activities. So you can see from this chart here that most people had either no problem or just some slight problems. We only had one person who mentioned they were extremely anxious or depressed, that were with a high in the red there. So this is interesting for 2 things. One is that we cannot expect a large increase in these measures at SVR4, SVR12. If we look at usual activities and self-care, the vast majority of participants said that they had no problems. So if you don't have any problems at baseline, we really can't expect to see an improvement in your ability to self-care or do your usual activities over time. So the one thing that I will be interested in is if the anxiety and depression, if we do see improvements in that, given that was the one that had the lowest amount of participants saying that they had no issues with. I'm not presenting the SVR4 or SVR12 results. This is just the baseline results, given we don't have a large number of participants at this point. You go on to the next slide. Then second question participants were asked was, we would like to know how good or bad your health is today. And they were given a scale numbered between 0 and 100. So think of a thermometer with a 0 to 100 scale, where 100 means the best health you can imagine, and 0 means the worst health you can imagine. Participants were asked to put an X on the scale to indicate how they indicated their health was today. And then they were also asked to write that number in the text box. And again, you can see that one participant has said they have 100% health at baseline. So we cannot expect that participant to improve their health with SVR4, SVR12 after the testing has been completed and after they've hopefully been cured. However, many of the other participants had less than 100% health. So one thing I'm going to be really interested in, and I can start to see, I think, in the data, even though the sample size is still really small, I'm thinking we might be able to see an increase in health rating over time. That, of course, is really preliminary, given we don't have all the data and the sample size is really small.
Thank you, Irene. So ongoing and future work, this slide highlights where we are now, the challenges we continue to navigate, the successes that have strengthened the program, and the direction we're headed next. Like for challenges, like many public health initiatives, this work hasn't been without challenges. We have faced ongoing funding limitations, particularly related to personnel capacity and the cost of testing, as well as losing funding for our Idaho Bureau of Laboratory Collaboration for confirmatory testing. We've also seen a lower than expected participation rate. This may be due to things like lack of awareness of the study or lack of champions advocating for enrollments. The full picture of the lower uptake is unknown at this point in time. And understandably, there remains a level of mistrust or distrust toward outside health programs, which we continue to address through relationship building and transparency. And also, despite some challenges, there have been several significant successes that have strengthened this study. We've received consistent support from jail staff and administrators who have helped facilitate clinics and encourage participation. 100% cure rate among the 12 individuals treated so far, which I think is an incredible outcome. And finally, our work has expanded into statewide collaborations and partnerships, helping align this project with a broader public health goal. Looking ahead, we're focusing on sustainability and empowerment. Some ideas for sustainability include incorporating a peer educator or peer counselor program within the county jail systems to engage participant champions, individuals with lived experience that can help build trust, encourage participation, and sustain engagement, even beyond formal study activities, as well as medical and jail advocates. Together, these efforts, learning from our challenges, building on our successes, and investing in peer-led engagement, our hope is that this work will continue to move forward and strengthen public health outcomes in correctional settings. Yes, if there's any questions, I probably talked too fast. Sorry, Kristen.
You did great. Thank you so much, Rachel. Questions?
Let me go. Thank you very much, Rachel. Could you,
Yes.
you and the team, please throw more light on why and how the focus on hepatitis C in correctional settings is crucial for the general public health goals, including the elimination of hepatitis C.
Rachel, did you want to answer that question?
Sorry, I guess I didn't realize it was a question. I thought it was a statement. I'm sorry, can you repeat that?
Yeah, I said why I would like to, could you throw more light? I guess you probably touched on that a little bit in your presentation, but could you expand on why the focus on hepatitis C among the incarcerated population is crucial for the broader public health goals, including that eliminating hepatitis C?
Yeah, absolutely. From some of the earlier slides, there's a large number of individuals who are incarcerated due to drug-related charges, and we know that drug use in people is a higher risk factor for contracting hepatitis C. So it's a disproportionate population that is affected by this infection. And if we can test and treat while they're incarcerated, while they're having someone help pass their meds, and while they're not using, then hopefully we can get them cured before they're out in the community, potentially spreading hepatitis C to other individuals. So we know that those people who are incarcerated are disproportionately affected and have a gap in those services. Also, not everybody who is incarcerated at the county level will be sentenced to the prison system. So they're two very distinct and separate facilities. So while those that go to prison will get treated, those that remain on county level charges, there's still a gap in treatment within those areas.
Yeah, so we have a question in the chat, and Question is, what types of incentives were offered participants beyond treatment?
Yeah, so there was no compensation for participation. The incentive was receiving free treatment, free hepatitis C treatment. We did have an opportunity to provide a gift card incentive for those that to come back for their blood work. That has not been utilized at this point. They've all been still within an incarceration system and we have not done the incentive for the gift card at this point, but the incentive was to be provided free hepatitis C treatment medication.
I may have missed it, Rachel, but are there plans to do like a return on investment analysis on this study at any point?
I'm not sure how to answer that, Chris. No, if you can help me with that one.
So Irene and I can definitely look at the return on investment based on the cost of testing and treatment per person. But it becomes a little complicated because much of the investment was not able to be utilized as far as the amount of drug that we received from Gilead because we didn't reach the 100 participants. So we can calculate it based on the cost per sort of participant, but we'd have to exclude like the overall cost of this project. And I think it would be stronger if we had more participants.
Okay, I have a question from one of our MPH students, and the question says, what will you change to try to increase participation? I'm not sure of what rules, regulations that are in place. How would you promote the information throughout the jails? Then the education and risk of not getting treatment.
That's a great question. I don't know that I know what I would do different. We certainly utilized our inmate liaisons in the jails that have direct contact with the inmates regularly. We posted information flyers. They also have like educational iPads within the dorms of the jail, and the information was posted there as well. I don't know how else we could have maybe encouraged participation more, other than I wish we could have gone in and had group discussions with each dorm or each section of housed individuals to discuss with them kind of the benefits of participating in the study. I do think that the medical staff played a key role in the participants that we did get. They were very supportive and encouraged individuals who either had a known Hep C infection or an unknown Hep C infection to participate in the study. But at this time, I really don't know how else we could have made it more robust and to get more people involved. I really don't know.
We can say that's a question that we've discussed at length in multiple meetings, is about participation rates. Like on paper, the study looks fantastic. We've got everything ready to treat this many people, and just trying to increase the enrollment being something we've really discussed.
Absolutely. Okay. And we anticipated even more so when we expanded our study to another county. We anticipated even more enrollments, and while we had, it was kind of at the same when we started, we had a pretty big rush, and then it kind of just tapered off, and that was the same with enrolling in our Bannock County Jail as well. It started out really strong with like 3 on the first day, and then slowly tapered off.
Okay, our public health students might be interested in getting a better idea of what are the specific primary research questions or hypotheses for this study.
You want the hypotheses, is that what you said?
Yeah, the more specific research hypothesis and
Yes.
research question.
I can pull up our the beginning of our abstract. It will just take me a second to pull that up.
And while that is coming up, maybe the other members of the team can also think about it. I don't know, I may have missed it from the presentation, but I'm not so sure the breadth of the county jails that are involved, but I'm interested in knowing what are the prospects for expansion and collaboration with all 7 public health districts in Idaho.
Sorry, Namdi, you might have to repeat that as well. Like, did we include the other 7 districts? Is that what you were saying?
No, I'm wondering if there are opportunities or prospects for expansion in the partnership to get all other districts involved.
Yeah, I my hope is that having this initial study project created that the roadmap or the timeline of how people could implement this within their own districts or within the state as well. It became very limited to how much I could branch myself out to the entire state. And I felt like we were it took a really long time to even just get to where we were enrolling. And then when we found out that we really should be expanding this throughout, like I just don't think I had the capacity to do that within the time frame of the study. And how do I oversee all 7 health districts within the state of Idaho during this research study? But that was also discussed on, can we reach out to, you know, all 7 health districts within the state? It just wasn't feasible at the time of us proposing that.
Really quick, I hope you guys don't mind me jumping in. Just a couple of thoughts. So with viral hepatitis, it's really costly. And so just to give the participants kind of an idea why other gels don't participate necessarily in hepatitis testing in the gel setting, because oftentimes if they know of an infection, then there's that obligation to treat. And medication is very costly. It's expensive. Hepatitis C can be an expensive infectious disease. And so, Rachel, is it still $18,000 for treatment costs?
That was according to the 340B pricing that I most recently pulled.
Mm-hmm. So that means $18,000 per person at 340B pricing, which is a really, very good. If we're thinking about that, if you're not getting at 340B pricing, then it significantly goes up. So that's a number one cost. If you have so many people in your county jail with hepatitis C, take $18,000 and times that, and your budget's fixed. So that blows your budget out of the water there. And then if you think about hepatitis and we do a cost analysis and how expensive it is, estimated cost is $10 billion annually for the United States alone to treat. That includes the direct medical costs, including treatment and management complications, and as well as indirect costs such as loss of productivity and impaired life. So just regular hepatitis C medical costs range from about $18,000. So that could potentially be the treatment costs. Once somebody does nothing with it and they continue to have hepatitis C in their body and it infects their liver and causes liver damage, then end stage $46,263. And then if we have to go into liver transplantation, because it can lead to that, it's $878,000 for a liver transplant cost. So that would talk about pre-transplant care, organ procurement, and then the transplant procedure itself, and then the post-transplant. So when we're thinking about that, that's really costly. And then when we look at the state and this is on Get Healthy Idaho. So there was about, from 2020 to 2024, there was 5,807 new chronic hepatitis C cases. So when we look at that and we think about the economic burden on Idaho in and of itself, we're looking at about $99 million potentially if these people were on Medicaid, and it would cost the state of Idaho. If we look at it maybe at a cost for the state of Idaho at all of those chronic hepatitis C cases, that's $99 million. So hepatitis in and of itself is very costly, and that's why I say this is so exciting that we are able to do that and to treat and stop that infection. So thank you, everyone.
Thanks, Danae.
Yeah, thank you, Danae.
So there's another comment in the chat. Sorry to cut you, Ryan.
Oh, go ahead.
It's, just curious, I wonder if you could ask the individuals that did participate what drew them to participate, and if they could share any feedback to improve participation. You may have already done this, but just a thought.
That's a really good question.
Yeah, that's really good.
Interviewing participants was part of our original study design, but because this group of people is such a sensitive population, we were monitoring it all along to make sure that we could interview at least 10 people who had participated, because less than 5, they can easily be identified, especially in such a small community. And we just have not reached that. We are still considering that as an option if we were to get enough participants. But that's why we pivoted to not interviewing people who were treated, to moving more towards a program evaluation and monitoring model, where we're planning to talk with the people who were actually involved in the program, especially the jail staff.
I have a comment that might turn into a question, sorry. But I think this is a really fascinating public health issue, because sometimes we talk about different strategies in trying to ensure public health. Like, do we target or do we focus on high-risk groups, or do we go for a strategy that's like a broad general population strategy, for example, looking at reducing injection drug use? And I think what's really unique about this case is we now have a cure for hepatitis C, so that changes this a lot. My question about return on investment was really because I think it's so important to show the quality adjusted life years, the potential for future infections that would be prevented from treating in a jail setting. And so, yes, I mean, I really appreciate Danae for saying, it would be like $100 million to treat all of the incident Hep C cases in Idaho right now. And we don't have that much money. It'd be great if Gilead or others could donate more treatment to treat all of that, or the state of Idaho could negotiate a reduced cost price to treat everybody. But in the absence of that, I really do think there's a real need for a approach where you go to where the incidence is greatest, and we know that's in jails as one of the places. So it didn't turn into a question, it stayed a comment. Thanks everyone for your patience with me.
Okay. Wait, there's another comment in the chat. Says, great study. As someone who treats patients wherever they may be, this confirms my experience and aligns with national/international data. Patients want treatment, and these medications are safe and have a very high rate of success. This study, although small, confirms that treatment can be successful in this setting. I've partnered with Kootenai County Jail to allow me to follow my patients into their facilities if I started their treatment. Thanks for that comment, Monica. Okay. Any more questions, comments? Okay, I guess that brings us to the end. I want to say a big thank you to the presenters for this great work, and also thank everyone for making our time to join us for this presentation. Thank you so much, and have a good rest of your day.
Thank you so much.
All right. Good job, Kristen, Rachel. Bye.